Hmm.
Just a moment. So the discovery of penicillin by Sir Alexander Fleming marked the commencement of antibiotic era. Formerly considered life-threatening infections can now only be treated, controlled, and also prevented. The use of the antibiotic has also altered the etiological organisms, the clinical presentation, as well as the treatment options for infections. Now, from the cut throat incisions that we were used to treat Ludwig's angina, now we have come along with much more conservative treatment options. We are giving incisions in Ludwig's angina, but not the whole neck incisions. Okay. So, according to the clinical appearance, how they are how the infections are classified. So, according to clinical appearance, acute infections, then chronic infections, and acute exacerbation of chronic infections. Okay, acute, chronic, and exacerbation of acute. Then, depending on the etiological agent, it may be bacterial infections, viral infections, fungal infections. Okay. Now, according to the source of infection, odontogenic infections, secondary infections of the lesions such as cysts or tumors. These are also called as super infections. Or then infection of the surgical wound, infections of traumatic wounds, and infection due to contaminated needles. What are the predisposing factors? The immunocompromised states mostly are the predisposing factors such as HIV infection or diabetic or poor hygiene control in immunosuppressant drugs for the long time, immunocompromised conditions such as nephrotic condition and other conditions like kidney problems and liver problems. So oral and maxillofacial infections are commonly seen by us dentists. Since in these cases, teeth are the source of infection. So early and aggressive management should be the norm to prevent the further the spread of the infection and deterioration of the patient condition. The patient may present to us with a large swelling, difficulty in breathing, opening mouth, but to understand how the situation lead to such alarming proportion, it is necessary to know the various stages of the infection go through. Okay. So, periapical and pericoronal periodontal infections, patient mostly are asymptomatics or may complain of mild occasional discomfort in the involved tooth. In stage 2, the organism spreads to the tissues, surrounding tissues of the tooth, and then enters in the medullary portion of the bone. The patient complains of severe pain as there is no space for the pus to escape. So the tooth is very tender in this case. If untreated, the pus now follows the path of least resistance from medullary to perforate the cortex. Okay, then it perforates the periosteum and appears in the soft tissue surrounding the tooth. Then we see pus in the soft tissue after in the stage 3. The swelling appears either intraorally in the vestibule or extraorally confined to the region around the tooth. Now in stage 4, the further progress of infection leads to the spread from one facial space to another along with the anatomical barrier. Okay. The large extraoral swellings or distress, trismus or respiratory distress. Sometimes in submandibular infection, when they cross the barriers, then Ludwig's angina and all, and sometimes mediastinitis also. Frank pus discharge may be seen through the sinus openings. So microbiology of microbiology or odontogenic infections are multimicrobial, gram-positive cocci, aerobic and anaerobic, then streptococci and their anaerobic counterpart, peptostreptococci, then staphylococci and their anaerobic counterpart like peptococci, then gram-positive rods such as lactobacillus, diphtheroids and actinomyces, then gram-negative rods such as fusobacterium, bacteroids, elicana and pseudomonas occasionally. Pseudomonas, they cause green type of pus and all. Okay, discharge. So the concept of facial space is based on the anatomist knowledge that all space exists potentially, okay, until fascia separated by the pus, blood drains or surgeon's finger. See, as such, you can't visualize a space, okay, unless the fascia separates and create the face. And let the fascia separates and create the space. So the fascia is separated either by pus or blood like hematoma, drain or surgeon's finger. Okay, you may also open the plane during the surgery. So that's why it is mandatory to drain a facial space infection because there is no blood supply there. Okay, there is no blood supply there because the blood supply fascia we have separated. So this is a hollow one. Okay, so there is no blood supply there, and then what happens when you are giving antibiotics or anything? They will not reach there because they go through blood. Correct?
Yes.
So when dental infections spread deeply into the soft tissue rather than exiting through the oral or cutaneous route, facial spaces may become involved following the path of least resistance. Facial space of clinical significance. On face, buccal, canine space, masticator space. Masticator space contains of masseter, pterygoid and zygomaticotemporal spaces. Parotid space. Then suprahyoid. Where is hyoid muscle?
No.
Yeah. Suprahyoid, sublingual space, submandibular space, which contains submaxillary and submental. Then pharyngomaxillary space and peritonsillar space. Infrahyoid, there is anterovisceral pretracheal space. This is pretracheal space. Okay. Then spaces of total neck like retropharyngeal space, danger space, space of carotid sheath. Okay. In facial layer, superficial layer and deep layer. In deep layer, superficial or anterior layer, then middle layer and then posterior layer. Now these divide, unite, blend and fuse to the various forms of compartments or spaces. This is basically a dissecting for body for the dissection, and now you can, when the fascia is separated, now you can see the spaces here. Okay, pretracheal space and all. After you separate the fascia, otherwise this is like this, and you will not find any space here unless and until it is separated. So this is the previsceral fascia, sagittal section. Okay. As you can see, geniohide, mylohide, then submandibular space here, anterior layer. So the infection of odontogenic infection, it goes to submandibular space like this. Okay. Submandibular space lies between, now you know, geniohide and mylohide. Correct?
Yes.
This is the vertebra. Okay. So prevertebral fascia, alar fascia. So this is retropharyngeal space and this is buccopharyngeal fascia. So this is buccopharyngeal fascia and this is alar fascia. So retropharyngeal space lies between buccopharyngeal and alar fascia. Okay. And when this prevertebral space, this extended, this come between the space between alar fascia and prevertebral fascia, it is called as danger space or space 4. Now buccal space, this is very important, most commonly encountered by or seen by us. So boundaries are superiorly zygomatic arch, inferiorly lower border of mandible, zygomatic arch and lower border of mandible. Okay, this is the buccal area. Okay, then anteriorly modulus of the mouth. Where is the modulus of mouth? Here, where the dimple comes. Okay, then posteriorly pterygomandibular raphe, inside where you give the block. Okay, medially masseter muscle, medially buccinator muscle and buccopharyngeal fascia, and laterally skin of the cheek. Correct? Okay. Now this is the buccal space involving the canine space also. This is a buccal space extending to the submandibular space. You have also seen many infections there.
Yes.
So this is zygomatic arch. This is lower border of mandible.
Mandible.
This is the mandible or this is maxilla. Okay. So this is lower border. This is the skin, outer surface. This is buccinator muscle here. Correct?
Yes.
Now this infection goes from the buccal root of molars also, maxillary molars also, and mandibular molar.
Mandible.
So the contents of buccal space is Stenson's duct, maxillary artery, buccal fat, pads. Sources of infection, maxillary and mandibular molar region or even premolars. Okay. If confined to buccinator, the infection drains intraorally in the buccal vestibule. Okay. You can drain it intraorally. The infection drains deep into buccal space and extraoral drainage. If the layer, it crosses the buccinator and the infection deep that then into the deep buccal space or extraoral drainage here. Okay, as we can see in previous photograph that it is extended towards the submandibular region also. The next is canine space. This is the buccinator space. This is the canine space. Frequently involved in odontogenic infections. Infrequently involved, sorry. The levator anguli oris overlies the apex of cuspid root. Cuspid is canine. Okay. So, and the origin of the muscle is high in canine fossa, where its insertion is in the angle of mouth and zygomatic muscle. If cuspid infection perforates the lateral cortex of maxillary bone superior to the insertion of the muscle, potential canine space become involved. Correct? Funny. Then masticator space, it consists of citric, pterygoid, temporal, These all spaces are well differentiated but communicate with each other, and buccal space, submandibular space, and parapharyngeal spaces also. So mesenteric space, it consists of mesenteric, pterygoid, and temporal spaces, and basically these are all well defined. But also then after when the infection flows towards the least resistance, yeah, then it can communicate with buccal, submandibular, and parapharyngeal spaces also, or they can interconnect each other. So sources of infection mostly third molars, pericornitis, dental caries, induced as abscess, infection of maxillary canine. Usually it presents as in labial sulcus swelling and less commonly as palatal swelling. The canine infection is less present in palate. It is more present in buccal side. Also by contaminated mandibular block infections or direct trauma. See, your needle should be clean. Okay. Contaminated needles can also infect. In these type of infections, mesenteric space infection, the clinical hallmark of the infection is trismus. The patient's mouth opening is
limited.
Yeah, he is not able to open the mouth. Now, next is sublingual space. Here, sublingual space. In my beard, you can't call. Now this is bilateral space, V-shaped space like this. Okay. Boundaries. What are the various boundaries? Superiorly, sublingual mucosa, then membrane, inferiorly, mylohyoid muscle. Okay, superiorly, sublingual mucosa, and then inferiorly, mylohyoid muscle, posteriorly, hyoid bone. These all spaces are in front of hyoid bone. Okay, so posteriorly, hyoid bone, and anteriorly, lingual surface of the mandible. Now, lateral borders, lingual surface of mandible again. Okay. And medially, genioglossus, geniohyoid, and styloglossus, all the tongue, extrinsic tongue muscles. Okay. Now, this is a cross section of sublingual space. Okay. This is the sublingual gland. You can see the tongue here. Oral mucosa, tongue, oral cavity. This is the offending tooth. The infection perforates through the lingual cortex. Yeah. Okay. This is below. This is mylohyoid muscle. This is neck, platysma. This is buccinator. Okay. So this is the sublingual space. When this is this barrier is crossed, mylohyoid barrier is crossed, then it will go to submandibular space. Okay. The communication is anteriorly with the submental space, posteriorly with the submandibular space. Okay. So in Ludwig's angina, sublingual, submental, and submandibular spaces bilaterally are involved. The sources of infections are premolars, periodontal infection of incisors, lingual injections, and infection of Wharton duct. So sometimes we give lingual infiltrations and all. Okay. So mind it, it may infect or it may lead to sublingual space infection also. Okay. So always block lingual nerve by on posterior region, not by lingual infiltrations here. Okay. Then one of the reasons may be silentinitis. What is silentinitis?
The infection of the salivary gland duct.
Very good. So the important clinical features: raised tongue. Okay, floor of the mouth is full, the tongue will be raised. Then white discoloration of the floor of the mouth. Then tender swelling of the floor of the mouth, and it will be a browny and erythematous. Means it is just like a red and just like a meatloaf we bring.
Okay.
Okay, yeah. Then mouth, open mouth. Dribbling of saliva. Then that will be a white color appearance here along the sides of the lingual parameter. There is dysphagia and dyspnea, difficulty in swallowing and difficulty in breathing also. When floor of mouth is raised, it gives pressure in the floor of mouth also, and it gives pressure in lower this thing also. So there is a difficulty in breathing also. And other toxic features are there. No extraoral drainage till now, only intraoral drainage is there. Differential diagnosis is cellulitis, or sometimes we say that maybe an infected cellulite has done this. The next is very important one, submandibular space. It is separated from overlying sublingual space by mylohyoid muscle. So above mylohyoid muscle, there is sublingual space, and below mylohyoid, it is submandibular space. Just move. So the boundaries are lateral boundaries, submandibular region, skin, then fascia and platysma, and lower border of mandible. Medially, mylohyoid muscle, hypoglossus, styloglossus. Inferiorly, anterior and posterior belly of digastric. Anterior and posterior belly of digastric. And posteriorly, again, hide bone. Hide bone was there in sublingual space also. Okay. So sublingual space is here, and submandibular is just below the sublingual space. The boundary is of the floor of sublingual space was mylohyoid muscle, and the roof of this is submandibular space is mylohyoid muscle. So mylohyoid muscle is the barrier. Okay. See, this is the sublingual region. Sublingual gland is there. Sublingual region. Here is the sublingual space, and now this is the submandibular. So this is platysma, which can extend. Okay. This is the hands. Okay. Digastric muscle. Now here genohyoid and other muscle, and this is the mylohyoid muscle which is separating. Okay, so this is forming the floor of submandibular space, and this is the roof of submandibular space and floor of sublingual space. Okay. So now you have understood where the space lies and how it will involve. The contents are submandibular salivary glands and lymph nodes, facial artery and Wharton duct, lingual nerve and hypoglossal nerve. Source of infection: mandibular second and third molar, sometimes even first molar also. Secondary to adjoining spaces, sometimes it comes from lingual space or submandibular submental space. The infection sometimes comes from lingual space or submental space. Again, the differential diagnosis is silentinitis with submandibular lymphadenitis. Then next is submental space. Boundaries are superiorly inferior border of mandible here, inferiorly mylohyoid muscle, posteriorly again inferior posteriorly mylohyoid muscle, laterally anterior belly of digastric muscle. Okay. Source of infection, mandibular incisors or from submandibular space. How the infection will present? The patient will present with swollen face, occasionally swollen neck hair, toothache or facial pain may or may not be a feature. There is often general malaise and possibly rigors with fever. Okay. So the signs are mixed signs. There will be rigors and fever also. Okay. So don't diagnose any anterior pain with this. Patient complains of trismus also. Patient have difficulty in swallowing, drooling, sore throat and hoarseness of voice. While examining, the specific attention should be paid to the location of the swelling, size, fluctuance, and any possible pointing and coexisting lymph node enlargement. So good oral examination should include first presence of halitosis, then evidence of intraoral pus draining, any tongue elevation or any sublingual or submandibular swelling, swelling in mandibular or maxillary sulci, okay, sulcus, then palatal swelling, especially of soft palate or uvula, then general dental state, how is the oral hygiene and how his dentition is, with the caries, periodontal problems, everything. Then patency of salivary outlets like parotid, sublingual and submandibular. Then nature of saliva produced, okay, whether it is a thick saliva or a clear saliva or any pus discharge. See, if the pus discharge is in the saliva, then there may be chances that it can be due to silentinitis or any salivary duct infection. Okay. Suspect teeth should be tapped with the metallic object to elicit any tenderness to the percussion. Swelling should be palpated bimanually, if possible with the finger of one hand intraorally and the second hand extraorally, pushing towards the oral side. Like this is one finger and this is second finger. First one finger is outside and one finger is inside, and you are just checking bimanually. This is bimanual palpation. Okay. The neck should be evaluated for swelling, lymphadenopathy, and possible tracheal deviation. So, etiology of major facial infection, teeth can contribute by number one, second molar, then root, okay, third molar pericoronitis. This is the premolar. Potential route of space, spread of pulpal infection. See, infection can go in sinus also. Here infection can go in buccal space also. Infection can go palatally also. In lower, infection can go in 4 directions, such as first is vestibule, second is in buccal space here, Third is in below the mylohyoid muscle to the submandibular space, and above mylohyoid muscle to the sublingual space. Okay, so mylohyoid muscle is the key factor in this. Correct?
Yeah.
Just a moment. Yeah. Any decay or caries reaching the dental pulp or pulpitis, it turns to spread by the supporting bone, resulting in periapical abscess, which in turn may spread supraperiostally. Okay. Then periapical abscess may occur in seemingly intact but devitalized teeth due to trauma, cracks, or decay under the fillings. The periapical or periodontal abscess may form as a result of chronic gingivitis and supporting bone soft tissue loss, such as periodontal disease. Note again that the tooth may be entirely intact clinically and radiographically. Okay. You may find the teeth clinically intact. Even when you take a radiograph, it is totally intact. So this periapical or periodontal space infection, spaces abscess can be result of chronic gingivitis also. Then erupting teeth, especially partially impacted lower third molars, they can result in inflammation and infection of the gum flap, preventing eruption. Like they form operculum with swelling pus around the crown in pericornitis, such as in pericornitis. So sometimes we keep on doing the operculectomies, okay, to prevent the pericornitis, but ultimately the third molar has to be removed. If it is not sitting in the, if the roots are not going into the canal, then it should be removed. Okay. Then retain roots supragingivally or subgingival. Sometimes we leave root pieces. Okay. The patient doesn't want to get rid of them. You can explain the patient that these can cause infection. So better to get it removed. Then they can develop cysts or tumors that can also range from odontogenic tumors, okay, to the primary or secondary malignancies also. Most are derived from the dental apparatus through, although benign, can nevertheless continuously grow and become secondarily infected on breaching the surrounding bone. So when the tumor grows, when it breaches the surrounding bone, such in case of malignant infections, malignant tumors, in that case, the pus may go and to the other spaces. And in such as in osteomyelitis, you can't see any clinical pus here sometimes. You can see pus in suppurative osteomyelitis, but in osteomyelitis, there is a bone destruction. Okay. Why there is bone destruction? Because of vascularity. Okay. There is less vascularity, so the bone get necrosed and dead. Osteomyelitis we are covering separately. Okay. Yeah, it is a very the clinical topic, and mostly it is confused with other pulpal disorders. So we are taking osteomyelitis separately. Okay. Then osteoradionecrosis occurs readily in the jaws which are going for this radiation therapy. So rarer are tuberculosis, actinomyces, and syphilitic osteomyelitis. Then most jaw fractures in the tooth bearing segments are, by the definition, compounds of oral cavity, can be easily infected by oral microbes. And extraction site again are comparable to compound fractures and are also surprising that infection is also relatively rare, because they have see, you have not in extraction site we have drainage of infection. Okay, if infection is there, we have opened the site, so the drainage on the least resistant site can be there. So there are less chances than after extraction that infection will spread again into the any space. But rare chances, huh? It may happen in 0.000001%. So it may be subject of either viral or bacterial. In salivary gland infections, the infections are oftenly superimposed on the obstruction of ducts mostly. If the duct is closed, then there is a stone or with a stone or a stricture also. Then the saliva will backflow, the microbes will backflow, and they cause infection. Tumors rarely also become secondary infected sometimes. In paranasal sinuses, if you are considering that, it may be primary infected, obstruct and result the facial swelling. As in one diagram, the infection was going to the straight above the tooth root to the sinus also. Okay. It may become infected secondary to the infection, teeth protruding to the maxillary sinus, sometimes upper premolar and molar. Upper premolar and molar teeth often do. In tumors or cysts may become infected, which are in consideration with paranasal sinuses. Fractures such as orbital floor are by definition compounded outside and may result orbital cellulitis. So any fracture crossing the paranasal sinus and all, it may tend to get infected, and we get a space infection there. So in investigation, careful history and examination will make the diagnosis clear. However, certain investigation will still be necessary, such as plain X-rays, like OPGs and all. Then occipitomental view, showing the maxillary sinuses. Then xylography. It can be used to suspect the gland obstruction. Okay, and sometimes we do CT scan of the this region, which is considered as gold standard. Then, but for salivary gland, this when you are palpating bimanually. Okay, bimanual palpation is very important. When you are palpating bimanually, you can detect any clinical finding for the salivary gland duct or salivary gland duct obstruction. Okay, it will become hard. The duct will become hard. Okay. Then maxillary occlusal views and lateral views. Then any puffiness in the cheeks, you can palpate for the parotid gland stones or this enlargement. And sometimes ultrasounds, yes, useful in confirming the collections as well as a guide to aspiration. So when you are aspirating and giving it for the culture and sensitivity, this ultrasound guided aspiration is mostly preferable. With axial and coronal views can demonstrate the extent of the swelling, then potential airway compromise, and it's invaluable to both the surgeon and anesthetist. However, patients unwell enough to potentially obstruct their airway should be taken straight to the theater rather than risk of emergency in a radiology department. Microbiology of any pus or discharge, the usual blood tests are there. In infratemporal and masseter space, superiorly, buccally, masseteric space. So this is the potential spread of infection from lower third molar. Like buccally, it spread to masseteric space, posteriorly it spreads to pterygomandibular space, superiorly it spreads to infratemporal and masticator space, inferiorly to submandibular space, Ludwig's angina, or anterobuccally to buccal space infection. So third molar infection can go anywhere in these 1, 2, 3, 4, 5 directions. Correct? Even in the canal space, there is a minor space, it can infect the canal also. Third molar, very notorious. Then pterygomandibular space, the pterygoid plexus, emissary veins, cavernous sinus thrombosis in lateral pharyngeal space, retropharyngeal space, and mediastinum and carotid sheath. Okay, the danger space, in prevertebral space. Okay. Now, what is the evolution of spaces of this odontogenic infection? In initial period of periapical contamination by bacteria, generally originating from root canal. Correct? Then clinical period with signs and symptoms of acute apical periodontitis and development of periapical abscess there. After that, the periosteum ruptured and infection gains access to the surrounding soft tissues. Okay, and it produces the phlegmon or cellulitis. Then final resolution period of generation of the repair tissue. Okay, so this is the main cascade, infection cascade. So what is cellulitis? What are its types? Okay, so cellulitis is any swelling. Okay, so the types are serous, circumscribed, acute cellulitis affecting the single anatomical space, or suppurative, circumscribed, acute cellulitis with purulent suppuration. Okay, one is without purulent suppuration and another one is with purulent suppuration. Purulent suppuration means frank pus, smelly pus. Okay, then again this is one is diffuse cellulitis, Ludwig anginas, peripheral cellulitis, necrotizing fasciitis. Last is chronic cellulitis, which is long-standing cellulitis. The clinical features or manifestations are sharp pulsating pain. The pain is pulsating one. It will come, go, like pulse. Okay. Then there is reddening and warmth of skin, and because the slight redness is present as compared to the surrounding area. Okay, and the temperature is raised. Poorly disseminated swelling that erase the skin folds and sulci. Sometimes the skin folds and all, so swelling is there, so you can see a smooth skin there. Okay, creases are gone. Loss of function, fever, okay, and malaise. Now, Ludwig's angina, it is a very dangerous space infection and a basic space infection, I can say, which is starting of the dangerous space infections, involving of dangerous space. Okay, if untreated, it may lead to death of the patient also. So it was first described by von Ludwig in 1836. Okay, 150 years back. Then what is angina? Angina is a choking sensation. So the definition of Ludwig angina, it is a bilateral, acute, rapidly spreading, septic, inflammatory, indurated, wooden hard cellulitis of the floor of mouth. Okay. Another definition is it is a gangrenous cellulitis of loose alveolar tissue which originates in submandibular space and spreads rapidly towards floor of mouth. Then by Gilly and K, it is a clinical diagnosis and its name given to brawny cellulitis occurring to bilateral submandibular region which also involve the sublingual space. Now, according to Kruger and Topazian and Ludwig, third molars, infection from third molar to the submandibular space involving sublingual space and submantle space. Then contralateral submandibular space is involved and submantle spaces are involved. Okay, it starts from one side, involves the submandibular sublingual space, then the pressure raises, it crosses the midline and goes to other side. And spreads bilaterally. So bilateral space infection, which includes submental, sublingual and submandibular spaces. It can spread backwards to the substance of tongue. Infection can reach to epiglottis. So if untreated, the infection will then go towards tongue. Swelling around the laryngeal inlet. The microorganisms involved are majority streptococcus, etiology, periodontal, pericornal or periapical abscess of mandibular molars, non-odontogenic causes like pseudo-Ludwig's, they are compounded fracture of mandible, okay, needle injury to the floor of mouth and fishbone injuries, silent anitis, okay. Now you can see the redness and brawniness. You can see here. And it is involving all the neck area. Now, signs and symptoms of Ludwig's angina are massive, firm, hard, broad, browny swelling with non-pitting swelling of neck extending down to the clavicle. Mouth is opened like this because the patient is gasping for air. Then there is dribbling of saliva also, raised floor of mouth, then shiny mucosa, white color appearance, stiff tongue with touching to the palate, dysphagia and dyspnea. It may lead to airway obstruction also and show the features of toxemia. Basically, it can cause mediastinitis leading to aspiration pneumonia and death due to respiratory paralysis. It can also involve pterygoid compartment and via pterygoid plexus it can reach cavernous sinus thrombosis. Retrograde infection we can say. Okay, it can cause septicemia and bacteremia because of hematological spread also. So general management, proper history taken and examination and investigations. Okay, then antibiotic analgesic therapy, anti-inflammatory drugs, fluid balance and airway establishment, okay, where required, removal of focus of infection, establishment of drainage, educate medical consultation and referral. In medicine and management, any sign of life-threatening infections are seen, the patient should be immediately hospitalized. Start aggressive antibiotic therapy. Patient is usually dehydrated, so replace with adequate fluids, and analgesics are given to relieve the pain. In surgical management, basically consists of incision and drainage and extraction of the source of infection. In incision of drainage, allow the pus to drain or to decompress within the tissues and to evacuate the debris and necrotic tissues. So it is done by Hilton's method. It is done by Hilton's method. We have a Hilton sinus forceps also. So after achieving anesthesia, the incision is made on the most dependent area of swelling. Correct? Most dependent part, incision is made. Here you are not looking for any cosmetic incision and all. Okay, this is a life-threatening condition. So incision is made on the most dependent part. The incision should be through the skin and subcutaneous tissue, parallel to the vital structures. Try to be parallel to the vital structures. Okay, not like this. It should be parallel to vital structure. Then you introduce Hilton sinus forceps inside the incision towards the pus collection, and the forceps is closed when it enters the tissue. The forceps is closed when it enters the tissue. Inside, when it is inside, then gently open up in the direction parallel to the important structures. Okay. Then the pus collected at this area, you will break the locules. The pus will collected will flow along with the beak of sinus forceps. The forceps is then removed, cleaned, and reinserted. See, you remove the forceps, clean it, and then reinsert. Okay, then reinsert to in different direction. Like first you have this direction, then this direction, and this direction. Okay, and open and allow the pus to drain. In this way, all the loculi within the abscess are opened. Once most of the pus is drained, the drain is inserted. One drain is inserted because the skin will close. So a drain is in rubber corrugated rubber drain is inserted, and the drain is then secured by the sutures. Now, factor complicating the space infections. What are the local factors? Septic focus, foreign body, tissue ischemia and necrotic tissues, inadequate surgical intervention. Systemic factors, debilitating conditions, immune deficiency states, disease states and affecting the healing like diabetes. The complications of space infection is first is septicemia and septic shock, then necrotizing fasciitis, respiratory embarrassment. This is the most dangerous one, and cavernous sinus thrombosis. In septic shock, it is potentially fatal with high mortality in the aged and in those with compromised immune status. The aerobic gram-negative bacillary infections are most common cause. The pathology is increased cardiac output in the face of decreased blood pressure, decrease peripheral oxygen consumption, and decrease systemic vascular resistance associated with multiple system organ failure. And when multiple system organ failures, the patient will collapse. The diagnostic criteria is the clinical evidence of an infection site. The patient has a high-grade fever or a low, means hypothermia. Okay, then tachycardia, tachypnea, inadequate organ perfusion as evidenced by poor and altered cerebral perfusion, hypoxemia, when SpO2 is less, elevated plasma lactate, and oleuria. The management is fluid and electrolytes, respiratory support, antibiotics, pharmacological support. So see, these are the complications of the space infections. Okay. Then necrotizing fasciitis and aggressive infection. These are long-term patients. The patient will admit and patient will be there for 20-21 days in your ward. Okay. The aggressive infection that affects the superficial fascia with undermining of the overlying soft tissue. The process usually occurs in fascia of trunk extremity, but can also be sometimes in maxillofacial region. Now we have a patient of necrotizing fasciitis for this region. So after 21 days, when all the infection subsided and all, then we took a skin graft from the thigh and reconstructed it. Then synonymous terms are, these are also known as hospital gangrene. In these patients, some super infections are sometimes there, pseudomonas can happen. Okay, so you have to be very cautious that the patient doesn't take any hospital acquired infection. So surgery and trauma leading to the inoculation of causative organism deep to the skin, and odontogenic peritonsillar infections, burns, superficial cuts, and abrasion contusions, then pyogenic skin lesions. So microbiology, most of the cases are synergetic mixed with mixed aerobic and anaerobic infections in necrotizing fasciitis. Clinical features usually begins with rather affected area is swollen, erythematous, and then the patient has low-grade fever. The site deteriorates rapidly with sudden pain worsening the erythema and the edema and generalized toxicity. As the disease progress, the pain subsides as cutaneous nerve become necrotic. The overlying skin become dusky with purple mottling, and you can see some boils or gas under the skin, and then it tears off. Finally, the sloughing of skin occurs. So management is serial debridement surgically, antibiotic therapy, supportive therapy, and correction of any underlying medical condition. See, this is necrotizing fasciitis, cervical necrotizing fasciitis. Okay. These are after the space infection drains and everything, then it happened. The debridement and then skin graft. Okay. So you can see the patient here. These all patients are immunocompromised patients.
Yes.
Again, one of this case. Necrotizing, cervical necrotizing fasciitis. Again, cervical necrotizing fasciitis. The respiratory embarrassment. So, in respiratory embarrassment, the etiological, the laryngeal edema with space infection. Clinical features are patient obviously is dyspneic, respiratory difficulty in supine posture. The management will be the conventional intubation, dangerous awake intubation, fiber optic intubation, tracheostomy with all its hazards, and cricothyrotomy in emergency. So as you can see, the tongue is protruding out. This is respiratory. There is no space. Okay, this is respiratory embarrassment. These are the corrugated rubber drains. Corrugated rubber drains. These are corrugated so that the infection can or liquid can flow through them. Okay, so these are placed for 2-3 days so that the site is patent and all the infection should be drained out. Now this is in respiratory investment. This is thumb sign of epiglottis. This is very classical sign mentioned in books only, but we were lucky to have a patient like this. So this is a thumb sign of epiglottis. As you can see here, thumb-like structure is there. So this is the compression. This is the compression of the epiglottis. Okay, also known as thumb sign of epiglottis. Now next is cavernous sinus thrombosis. These are two sinuses located on each side of sella turcica of sphenoid bone and connected by intercavernous sinus. Correct? The cavernous sinus communicate directly or indirectly with virtually with every important venous structure in head and neck. So etiology is most commonly it is caused septic and thrombosis from the odontogenic infection. The infection can also be carried from sphenoid and ethmoid sinus, otitis media, mastoids, or infratemporal fossa. So it is connected to all the surroundings. Clinical features: diplopia as early sign, then proptosis, ptosis, chemosis, and oculomotor palsy with decreased visual acuity. The headaches are localized to the frontal and retroorbital regions. Generalized sepsis with swinging temperature curve. Okay, this is also known as picket fence fever. Sepsis with swinging temperature curve. Sometimes the temperature will raise down, raise down, raise down. So it will act as a fence or known as picket fence appearance. Then photophobia, eye pain, dysesthesia over the forehead region, and in late stages it may show as the ocular movement, loss of ocular movement and convulsions, and even the patient is comatose. Okay. Management is early diagnosis with high dose of IV antibiotics, hypernization, because cavernous sinus you can't drain. Okay. Hypernization may decrease the mortality. The surgical explanation and drainage are rarely done. This is an old patient having cavernous sinus thrombosis. Unfortunately, we lost him. Okay. This is the eye. When you see the this complication over this eye region, the swelling, the rupture of the vessels, and the hematomas. So management of severe maxillofacial infection, first is antibiotics, early surgical intervention and airway management, local wound care, supportive care. In surgical management, aspiration, decompression. See, if the patient is, you have seen the patient and you are not able to do incision and drainage over this area in your clinic, at least what you can do, take a wide bore needle, put it in the infection and just aspirate. So that the airway obstruction and that pressure will be decreased, and then tell the patient to get hospitalized fast. Okay. Then incision and drainage, and the principle of incision drainage is it should be liberal, patent, passive, and dependent. Correct? And then debridement of the tissue. If needed, tracheostomy is done. These are the various incision sites. For this is for temporal infection. This is for submandibular, submental. This is for neck infections. Hilton forceps for mesenteric space infection. Go, expand, come out. Go, expand, come out. Breaking of the locule with the gloved finger. Breaking of the locule with the gloved finger, so that with instrument you can injure, na? But with gloved finger you can't injure. For patency, rubber corroded rubber trays are placed. Okay. Previously we use ribbon gauze also, but now these are not recommended. Okay. I have shown this photograph because this may lead to complication. So this is not to be used. Use only corrugated rubber drain. Don't use ribbon gauze for space infection. It is potentially blocking the space, not allowing to drain. Okay. So don't use this. It can be used for debridement. You put ribbon gauze inside, okay, rotate it and then take it out. It can be used for debridement, but not for drainage. This is the temporal space drain. This is the submandibular space drain. Okay. So next we will discuss about osteomyelitis. Okay. So done for today. Next class is on Monday.
Okay. Monday, is it?
Yeah.
Okay, sure.
Yeah.
Okay.
Bye bye. Take care.
Bye bye.